Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Welcome to this episode of the Neuromodulation Podcast. Today, we're pleased to have Professor Poree, who holds the position of clinical professor in the Department of Anesthesia at the University of California, San Francisco, where he serves as the director of the Neuromodulation Service. And he also happens to be treasurer of the International Neuromodulation Society, which produces this podcast. Welcome, Dr. Poree. Thank you for being with us today.
Thanks for the invitation.
Could we start with giving our listeners a little background about your work and how you became involved with neuromodulation?
Well, I became involved in neuromodulation 40 some odd years ago. Long before going to medical school, I was a research scientist working at UC Berkeley and at Johns Hopkins, and looking at the impact of stimulation in various parts of the nervous system on the functioning of the pain pathways of what my research was primarily involved in. After a few years of that, I decided to then endeavor to medical school for the specific purpose of investigating and pursuing a career in advanced pain technologies, including neuromodulation.
That's awesome. So, we felt that it was really important to kick off things by reviewing what even is neuromodulation and which patients can benefit from it, because that is one of the most pressing issues in neuromodulation is raising awareness. Not only are prospective patients not aware, but it's surprising how many physicians are also unaware of neuromodulation.
Well, in fact, I would argue that everyone, even the general public, is well aware of neuromodulation, just not necessarily the term. For example, pretty much anyone on the street, if you say to them, have you ever heard of a device that can electrically stimulate the heart to keep the heart going? Most people would be aware of a pacemaker or a defibrillator or something of that nature. And that's just one form of neuromodulation. In the last, let's say, 20, 30 plus years, the field has expanded to include a variety of anatomical targets for a variety of disease states. And that is what is maybe not as well known. And especially since the ecosystem of neuromodulation is growing at such a rapid pace that new things are being developed all the time and becoming part of clinical practice. And it's typically not taught in medical schools. It's not taught in primary care residency programs. And therefore, it catches people off guard when they hear things that they haven't necessarily heard in their standard educational training programs. So from the broad spectrum of what is neuromodulation, neuromodulation is nothing more than the interface between the nervous system and some form of technology. And since the entire body is engaged with the nervous system in some way, many aspects of the body can be interacted with through computer technology. And so that's the global sense of neuromodulation. And then we have various specialties, various medical specialties and engineering specialties that address the specifics of that particular disease state or particular type of physiology.
That's an excellent clarification. Why is it not taught in medical schools?
Well, it really has to do with the foundation of our medical training and our medical understanding. I don't think that only in recent years do we approach patients and medical conditions from a more holistic standpoint. Medicine is still structured in much the same way it was several hundred years ago, which is based on organs systems. And so we have the cardiovascular system, the GI system, there is a neurology system, cardiovascular blood systems, skeletal systems, immune systems. And so people specialize in those systems. and they become very rapidly specialized and focus their attention on those systems. The nervous system engages all of those systems. And so it might be a small part of a particular structure in the medical training and the medical infrastructure, but in fact, it spans the entire scope of medicine. And that's just not the way it's structured. And as a result, he gets left behind. Most cardiologists that I speak with are unaware of the fact that some of the national guidelines for the treatment of angina include spinal cord stimulation. It's not first or second line, but it's third or fourth line. But it's so far down and out of their daily realm that they don't even know that their own society supports neuromodulation for cardiovascular conditions. So similarly, the relationships between the brain and the GI system, the brain and the immune system, the brain and the cardiovascular system, these things have been largely unaddressed prior to 30, 40 years ago. And the exploration of these things is growing rapidly, but they're not at the foundational basis of medical education. They're not, well, they haven't been in the basic medical textbooks, but that's changing. That's certainly changing. For example, the textbook on current diagnosis and treatment of medical conditions, it's a yearly, very thick textbook. In 2017, there was no mention of advanced pain treatments of any sort, no mention of neuromodulation in any sort, but the editor of that particular textbook was at UCSF, and we got to talking. And now, for the last several years, that textbook now has a significant section in it on advanced techniques, including neuromodulation. So it just hasn't been part of basic medical school or residency training because there's so much other material to cover, and you can't put it into a group by itself because it actually encompasses all the other systems together. And so it's been difficult for medicine to go in the realm of looking at the whole organism instead of individual organs. But there's more folks pushing in that direction.
Yeah, that makes a lot of sense, particularly touching on what you'd mentioned about the advancements rapidly changing within the field of neuromodulation and the half-life of medical education. By the time they've graduated and gone through medical school, then the advancements they may have, if they have had the opportunity to have learned about neuromodulation and how it applies to their specific field of practice, is probably outdated by that point.
Indeed, I find that my specialty is pain medicine. And if I look at the neuromodulation I was doing 15 or 20 years ago, it barely resembles what I'm doing today. So the field is growing rapidly across specialties, and there's a lot of material there to understand and get exposed to. And it tends to be in the more advanced stages of each particular specialty. The neuromodulation components are the more advanced. So as a result, it doesn't usually make it down to the basic of residency and medical school.
So, how have you helped to educate referring physicians to understand the value of neuromodulation?
Well, two different approaches, making sure that I spend a fair amount of time in my own community, giving lectures, discussions, webinars. I have a couple of lectures about the global nature of neuromodulation that I have referring physicians in, as well as my patients watch. That's on YouTube. And more importantly is just to identify patients I've treated and then reach back to their primary care providers or their specialty providers and track their course and discuss it with them and say, well, here's how I think we can help this. And this is how this patient is responding. And you have other patients that are similar to this, and you might find that they might benefit as well. So it's not a sort of single pitch to everyone, but individualized pitch to any given provider and for any given particular specialty, and try to reach out. If you ask me, where do I think those of us in the field of neuromodulation may have been shortcomings in our service, it's been that we've done a lot of good work in research and education and distribution of our knowledge to ourselves. So preaching to the choir, so to speak, with not as much outreach to those folks who don't know much about us, don't think much about us, or don't understand how their patients may benefit by interacting with us as well. So I think we all need to do a better job at that and open up the discussion far beyond the circles of our own particular societies and our own particular groups.
Well said. And you mentioned also taking into consideration an individual patient's wishes, because that's assuming that they are appropriate for a course of neuromodulation therapy, that it aligns with what they're wanting, and really helping guide other physicians to be able to hear those options and then offering neuromodulation as a potential solution to meet those wishes.
And that's where I spend most of my time when I first start discussing these concepts. Before I even mention the word neuromodulation to a patient or even the components of neuromodulation, it seems that we need to spend more time understanding the expressed wishes, value systems, objectives, and lifestyle that a patient's seeking. And so I tell my patients that they need to teach me what it is that they're trying to accomplish in their life, what their goals are, what their value systems are. And then that allows me to better structure the recommendations I have for helping them achieve their goals. But ultimately, especially as a pain physician, I'm here just to help guide them in making decisions relevant to their wishes and their desires, not trying to impose my own thoughts about this, but making sure I understand where they are and then approach it from there.
That's amazing. So you mentioned that you are working in pain, and that seems to be a common misperception, that for those who do know the term neuromodulation, that they associate it solely with pain, but it can be used to treat a variety of common conditions. Could you talk a little bit about that?
Oh, there are so many. So when we're looking at DBS, there are a variety of conditions that are treated with the stimulation of the brain directly, and both from invasive technologies and non-invasive technologies. So we know that since probably the 30s or the 40s, there have been stimulation of the brain for depression. And while that practice still continues today, it is associated with some side effects and some memory loss and some other issues. And so it's often thought of being rather drastic. However, transcranial magnetic stimulation, far less side effects, no real cellular damage or memory loss issues. And yet it is now FDA approved for the treatment of depression. So you can come in and get treatment during lunchtime and go back to work. And so that's how fast or far that particular field has moved. We have treatment for Parkinson's disease, the tremors of Parkinson's. At UCSF, there is a tremendous amount of work being done on a variety of conditions, including tinnitus and OCD and pain, all with deep brain stimulation, seizure treatment with stimulation as well, brain stimulation. And for non-invasive, not only is TMS useful for depression, but it has gaining FDA clearance for other psychiatric diseases as well as pain and headaches and post-traumatic headaches and things of that nature. You move down a bit, we have the Second Sight program, which would allow folks who are blind to see maybe not the clarity that you and I have, but to see light and shadows, which was a revolution. We have stimulation to help with snoring and stimulation of the phrenic nerve to help with people who are ventilator dependent, can't get out of the house, can't get away from a large machine and need to be dependent on a ventilator at all times. There are folks now who can get off the ventilator and just have an implanted neural stimulator to help them breathe without the use of a ventilator. And pain is just one of those things that, aspects that I'm dealing with spinal cord stem and peripheral nerve stimulation. We have gastric stimulators that help with GI motility. We have auditory cochlear stimulators that help with hearing. And so the list goes on and on. And there's a wide spectrum. Most specialties have people that have subspecialty training to use neuromodulation devices in various disease states. And that's why our national and international societies of neuromodulation are unlike most other medical societies because it's not organ based, it's systems based and incorporates medical specialties from all walks of the medical profession.
Yeah, I mean, incorporating all walks, but all different facets of things that you've mentioned affect quality of life tremendously. It's just amazing. And since COVID, we're seeing even more of a need for therapies that help support these individuals after going through this.
Absolutely. And thanks for mentioning COVID. It's one of the things I didn't mention. So a vagal nerve stimulator is FDA approved for the treatment of COVID symptoms
Mm.
because the immune system and the nervous system are connected. And by interrupting the cytokine storm or the inflammatory response to COVID, which is what actually ends up putting a lot of people in the hospital on ventilators, if we can decrease that response of the body by interacting with the nervous system that connects to the immune system, there can be an impact there as well. And that's why the FDA gave emergency clearance for its use during the COVID epidemic as well. So it's really a wide spectrum. And that interaction between the nervous system and all these other areas of the body, there's not a course in medical school that covers that. And so that's why connecting those dots hasn't been as easy as one might think it should be. But hopefully, with more systems approach to training and understanding might be a little bit easier. But our medical system still is divided, our insurance still divided by the specialties, and you get your certification by the specialties. No one has a certification in global neuromodulation because it's just too global. But it's important that we get the word out and get people involved. And I think most importantly, have our patients ask the question, is there anything more that can be done to help me manage whatever the symptom is that they're dealing with, whatever the condition they're dealing with, and see if there's something other than our more traditional approach, which is just basic surgical approaches, which is quite useful for a lot of things. But sometimes that connectivity between the nervous system and whatever the function is that one is stressed with trying to deal with needs another approach. And so asking what other approaches are available is key for both our referring physicians as well as our patients.
Well, that's really key in all facets of healthcare throughout the world. A lot of people just go to their doctor's office and expect the reverse of the approach you take. They say, okay, doc, tell me what I'm supposed to do. And I think that people just aren't aware that they should be part of their own care team.
Well, I agree with you, but you do bring up a good point, which is, are there regional differences in that approach, societal differences, cultural differences? And having worked outside this country a bit, I have noticed that those differences are really significant, and the types of discussions between patients and doctors can be very different than what I experience, let's say, on day to day at UCSF.
Yes, absolutely. And then, I mean, are all of the technologies that you've mentioned being innovative necessarily available in various regions throughout the world?
So that's one of my greatest desires before I finish my career is to work on more projects directed at bringing the benefits of neuromodulation to those that don't have it in their normal medical environment. Even in European countries that have plenty of skilled and very good doctors that do neuromodulation, they still struggle a bit with the ability to, and even here in the United States, we still struggle with the ability to offer those therapies for whatever insurance or other reasons there might be. But more so in places where other aspects of medical care are difficult to come by. And because it is technology, it's a sort of thing where the cost can still be exorbitant because the economics of scale are not there yet.
Mhm.
And one of the things that I struggle with in my field, knowing that I'm using devices that are relatively expensive as they are right now, but I wonder why they couldn't be cheaper. And if we could find cheaper versions of them, would that allow us to expand beyond the limited access that we currently see around the globe?
Mhm.
One of the things that I often compare this to is cell phones. When I first went to work for a short stint with a cousin of mine who's a surgeon, a missionary surgeon over in Kenya. That was in the early 80s. And a cell phone was something the size of a shoebox, and only the very wealthy had it. In the hospital that I work with him at, there was a 300 bed hospital with 600 patients. There was one telephone that was used for emergencies. And in addition to that one telephone, there was one bottle of AZT that was kept on the shelf. And the purpose of that was theoretically that if someone was stuck with a needle that was a patient that had AIDS, they might take it prophylactically, but one bottle of that. I go back to work with him again 15 years later. And when I get off the plane and was just driving down the street, I saw that people were selling cell phones in the street just for $10 to $15. You could buy a cell phone. And I said, well, what good is a cell phone if you don't have service?
Mhm.
Well, then he pulls up to a gas station and he tells the attendant to put $10 in the tank and $10 on the phone. And the fastest growth of cell phone technology was in Africa because the landlines were almost non-existent. And so by the time the technology was affordable to the masses, it skipped over landlines and everyone had a cell phone because they could get one for a few dollars. And then when I got to the hospital, I walked in and found out that they had a full-blown AIDS clinic and they were doing multi-drug treatment, and people who had no money were still able to get the therapy. And so very different than the one bottle of AZT 15 years earlier. So I wonder, that within a span of 15 years, that technology in both cell phones and AIDS treatments went from being virtually unavailable to anyone on the continent to the point where it was, both of those were quite available to many people or most folks. And yet when I look at the trajectory of neuromodulation over the last 20 to 25 years, we know that the patients are there. We know that the need is there. And yet our penetration of the population who could benefit the most is still rather small. And the growth has only been in small percentages. And that's a struggle that I would like to delve into a little bit more. And I think one of the issues there is to find ways to get the technologies cheaper, just like most other things in technology, our computers, our cell phones, and all these other things have gotten cheaper over time. But we haven't necessarily seen that in neuromodulation yet, but hopefully we'll get there.
Yeah, that's an excellent point. I mean, affordability and at least in the US insurance and the limitations that that can place on families as well. Families is something we haven't touched on, but some of the conditions that you mentioned, I'm laughing, but because snoring, one of them, maybe not one of the most severe, but that is, there's implications for relief for other family members as well, such as spouses. I've had the pleasure of interviewing some patients who have chosen neuromodulation, and one of them has said that he feels like Superman since because he can hold his grandchildren again, something he thought he would never be able to do. So those implications extend beyond his quality of life, but also for his grandchildren and his spouse and his family. And I think that's important to note as well, the wider reach of the treatments.
Absolutely. I see this most commonly in my specialty. I see this in and the patients I treat that have intractable pain due to cancer. And oftentimes these patients are extremely sedated and not very engaged with their families at a time where you would hope and they would wish as well. They often wish that they had more engagement with their families at the critical time of life and struggling with diseases that are life threatening. You want to have oftentimes more engagement. And yet, in order to control their pain, they're usually far less engaged. And so I have certainly had many family members tell me that after engagement in neuromodulation technologies, it was as though they gave them back their loved one for a period of time that they thought they had lost because they couldn't communicate with them anymore because of all the side effects of medications. So it certainly has a huge impact on the family as a whole. And they're actually sometimes the biggest fans and advocates once they see how impactful it's been to their own family members.
Yeah, those stories are just amazing, and we need to hear more of them. So you mentioned the FDA. We know that it's trialable, that its forms are reversible. Could you explain in a little more detail about that for someone who hasn't had an understanding?
Not all, but many varieties of neuromodulation, spinal cord stimulation, for example, electrical therapy, peripheral nerve stimulation. A lot of these involve the interaction between sophisticated computer programming and small electrodes that are placed under the skin or inside the spine with a needle, and then connected to the complex detailed computer programming to an external box. So that's really, I think, an unusual aspect of this therapy compared to, let's say, a standard surgical approach where you have to open the patient up to explore what you're going to do. Here, you can place your wires through needles and just test them for several days to even a week or two and explore how they're going to impact the patient. And the patient explores how they interface with the device and how it impacts their life without really committing to surgery for the trial phase. Once the trial phase is over, the wire is pulled out from whatever location it might be in or the catheter. And then the patient can discuss it, think about it, and down the line make a decision. Is this something I want to pursue long term? And if so, repeat the procedure, but instead of having an external computer with a battery, have something that is just placed underneath the skin, the size of a pacemaker or a little tiny, this is actually a little bit bigger than one, but you can see that that's about the size of an average device that will have both computer and the battery included in it. And the battery can be recharged through the skin. So just by putting a little rubber pad over where it is for an hour or so, recharge it. And those computers and devices are on average good for about 10 years. After 10 years, you just replace it with another without having to change the leads or anything. So that trial aspect is, I think, key for most of the devices we have. And it really help people gauge if it will achieve the level of benefit that they're looking for before they commit to any surgical implantation. And even then, it's usually something that just placed underneath the skin. So as things go, it's pretty minimally invasive all around.
Well, and particularly with SCS becoming less minimally invasive as the technology improves and the battery life is increasing, it really makes me wonder a decade from now where things could be. It's really incredible.
Well, now we have permanently placed electrodes and they're connected to receivers that are the size of a dime and they can be powered and programmed externally. So that's where we are now. And if you look back, turn of the century of 2000, we were looking at devices that looked more like a pager in size and implantation. So you go from that to something the size of a dime. We've already made huge progress in that direction, but the field is moving rapidly and getting more sophisticated every year. I find that going to both my national and international society meetings, the International Neuromodulation Society and the North American Neuromodulation Society, every time I go, I find new technologies, new indications, and new therapies that I hadn't even imagined. It's moving that fast that every year or two, there's something new on the horizon.
The implantables made me think of your phone example earlier from Africa, how it went from the shoe size to now how it is, and everything's getting smaller and smarter. And about patient selection, could you speak a little bit about that and how physicians can feel more comfortable in referring appropriate patients?
We certainly have many therapies that are treated effectively and efficiently at cost reasonable nature with either surgeries or medications. But sometimes we find that multiple surgeries over the course of years or multiple drugs and the side effects of drugs over the course of years don't always get the same outcome that we're hoping for. that same
Mhm.
outcome the patient's looking for. And so I'd say if there's a standard therapy that has minimal side effects and minimal problems and minimal risk, those therapies that are well established, let's say for 50 to 100 years, certainly should be explored. But many of our chronic diseases, that's not the case. And in those situations, it's really important to balance all aspects of care. And while I talked about the fact that neuromodulation can be expensive up front, we've done a number of studies, we call them a SAFE analysis, where SAFE stands for safety, appropriateness, fiscal neutrality, and effectiveness. That even though the initial cost might be a bit higher up front, if that therapy lasts for 10 years, it actually is
Mhm.
far more cost efficient than something that costs 20% of that, but then has to be maintained at that cost rate for those 10 years. So we need to look beyond the initial phase, but we need to actually do our economic analysis, safety analysis, and efficacy analysis for the duration of the time that we're treating the patient. And that's not something insurance companies typically look at. Hospitals don't look at it. Hospitalization is something you do in an acute phase and you go to the hospital, then you leave the hospital. No one says, oh, well, you're going to be engaged with this hospital from now until you're 100. That's not it. And the turnaround time for individual commercial insurance plans for individual patients averages 2 years. Well, no wonder the insurance companies want to avoid this complication or this particular cost, because 2 years down the line, it might get shifted to another company. Whereas for those of us who deal with chronic disease, like chronic pain, when I discuss this with a patient, I ask them, I said, look, when we're discussing a treatment strategy here, the strategy has to be until you're 100. Now, that's just a random number, of course, but I came with that number because my grandmother lived to 104, and I figured everybody should get to be 100. So let's have a plan that at least gets us to 100. And therefore, thinking in terms of 6 months to a year doesn't make sense. When a person buys a house, a lot of folks don't look at it. I'm just going to be here for a year or two. They say, well, look, I just signed up for a 30-year mortgage. So what's the long-term implications of that decision? And when we're treating patients, it's for their life. It's for the quality of their life, not for the quality of the next 6 months or until they change insurance plans.
Right.
And so when we're doing the analysis and the fiscal analysis of these things, we have to think in that fashion as well. And that's not the way that we typically think about things, at least in this country. I think maybe in countries that have more of a global national healthcare plan might look at it more in that way, but our experience here is not that way typically, but maybe it should be.
Yeah, I mean, I know that's one of the benefits of being a member of the International Neuromodulation Society and the local regional society, in this case, NANS, the North American Neuromodulation Society, the advocacy work and working with insurance companies to get them understand the benefits. I mean, I'm wearing eyeglasses, and had I gotten laser surgery, overall, the cost would have, with supplies and everything, would have compensated. But would have I had the same insurance company over the course of those years? No, probably not. And it's very different, but in some ways, there's some parallels there.
Absolutely.
What about resources for physicians wanting to make a referral if they're not in a larger healthcare system that has a pain specialist? Where can they go? Where do they start?
Well, so that really still continues to be a struggle. Certainly, the more remote a medical practice might be, the less resources they might have. But I wouldn't say it's insurmountable. I've treated patients who come from very remote Native American reservation type places that had, one doctor, one clinic, and no other access. But that doctor, actually, in this case, it was a patient that reached out and requested a referral to the university many hours away. But I got to see him, and after a bit of time working with him, he's got a spinal cord stimulator and gotten off much of his medications and is doing better with that. But it requires both physicians and patients to be a little bit more persistent about advocating for themselves.
Mhm.
And I think for the physicians who are in remote areas and wondering if there's ways that they can get their patients access to this, I'd say every state has an academic center of some nature, and trying to get them to that center, if there's not someone else closer by. When I was in private practice, there were significant constraints, and there still continue to be constraints even in the academic center, but the ability to treat a wider spectrum of patients in the academic centers are a little bit easier than they are in the private practice sector. And I have found many patients who are ideal candidates for neuromodulation who had various governmental insurance programs that may not have gotten them into a private practice clinic, but they could certainly get access to that kind of care through the university setting. It's still a challenge, but we open our doors to everyone. It's not easy all the time, but I think asking for, board certified interventional pain physician for the sake of pain related therapies. And when you look at DBS therapies, I think while there probably are a few that are in private practice, the vast majority of that work is certainly occurring at larger institutions and academic centers. And so I don't think there's any negative thoughts from either patients or referring physicians from more rural communities asking for second opinions and reevaluations at academic centers. And I see many of my patients come from 3, 4, 5, 6 hours away, and I work in collaboration with their local pain doctors as well as their primary care doctors, and we come as part of the treatment plan and treatment package for that patient. And there's usually someone to work with. Just reach out and ask for collaborative efforts by your academic centers, I think would be a good approach. If you're not in a major metropolitan area where you trip over a neuromodulator every 20 feet, then that's a way to try to get access to the therapy.
That's great. And of course, we have the resource of finding a clinic or physician on the International Neuromodulation Society's website, neuromodulation.com. But I love that story about the Native American who had advocated for himself. I mean, I think I asked about patient selection with respect to physicians, but patients might consider advocating, when they've exhausted other treatments.
I have found, maybe as much as 20% of the patients that I end up treating with neuromodulation have advocated for themselves through their medical support groups. There's discussion there. Certainly reaching out to the societies like International Neuromodulation or the NANS website for particular details and then getting links to doctors is a way. But sometimes that doesn't come with an understanding about the patients that are like you. So I get that there are a number of folks who talk among themselves among support groups, and then based on that discussion, then seek out referrals to see me or go to an academic center because they know someone else with this condition that is doing well.
Right.
So I can't speak highly enough of the patient ambassadors and advocates that have helped other patients. That is actually the best way to spread the word is patient to patient. And I find that those patients usually come having done a lot of their homework. And these days, it's huge difference from the VCR tapes I used to hand out 20 years to now getting access to, all companies, all devices or have educational website information. And most of them have patient ambassadors that a patient can speak with even before they talk to the doctor, they can speak with the patient with their same condition and understand what the pros and cons of that therapy have been for that patient. So for those who have internet access, it's a lot easier than it used to be. And I highly support not only our medical societies that specifically focus around neuromodulation, but also I'm very glad to see the support systems, the community patient support groups are exploring this and often keep up quite a bit on the latest research and often come to me asking about the latest research that's out there. And I'm impressed that they heard about it and we can talk about it in greater detail. So all of those avenues are available. And at least in our environment, our institution, our primary care physicians in remote areas that want to reach out and ask questions or have a telephone consult. That's one other thing I'd like to comment on. The month or two before COVID, our telemedicine rate in our clinic was less than 5%.
Mm.
Within the middle of March 2020, our telemedicine rate went up to 95%. And while our clinic returned to seeing patients in person, that telemedicine rate has only dropped down to about 70% now. And we continue to see a lot of people, and that opens up a lot more access. Having to drive 3.5 hours, spend $25 on parking, and wait in the exam room for an hour to see the doctor for 15 minutes and then repeat the process going home. That's just not a viable option for a lot of folks. And now they can spend that 15 minutes on a telemedicine visit with me to discuss theories, options, programming issues, just subtleties that make it so much easier. And as a result, I think we have significantly broadened our reach and access to care to people in communities that wouldn't normally get it. So as bad as COVID was for all of us, the rapid development of telemedicine and Zoom like we're doing now
Yes.
has drastically changed medical practice forever, as far as I'm concerned.
Yes, with implications for insurance as well as they've changed, allowing for more telehealth. Now we're wanting to stay home when we were dying to get out of our house, but
Get out of the house, but not necessarily a 3-hour drive to get
Oh,
to your doctor.
right.
And with these devices being computers, they're being fine tuned for the individual therapy of an individual patient. They do need to be fine tuned, and they need to be fine tuned with changes in the programming. So I think a number of devices are moving in that direction, but I think it'll be a short time before all devices have remote programming capability. I know the cardiac side of the things have already started to pursue that, and some DBS work as well. And some number of folks are working on that in the spinal cord stim realm. But the idea that if I can communicate with your device over the internet and read it and explore it and make programming changes remotely, like I can do with so many other things, then the need to come in for that individualized fine tuning to the office just isn't there anymore. So that I anticipate we'll see will be the norm within a few years.
Yeah, I could see that too. Well, Professor Poree, I feel like we've really covered the gamut of what is neuromodulation and really the whole point of needing to have this particular discussion about raising awareness. And I love what you shared about patients. It's the word of mouth. And I had spoken with one patient. We have a phrase here in the United States, the poster child of something, of wanting to be an ambassador. She wants to be the poster senior for neuromodulation because she just wants to say from the rooftops all that it has done for her. And the more awareness, in addition to this new podcast that we're launching, the more we're going to be reaching that goal.
Fantastic. I agree with you. And I hope to see more of these podcasts and get more, not only physicians involved, but more patients as well.
Yes, absolutely. Absolutely. And sharing their stories is just, it's so compelling. Is there any advice that you would like to end with that I haven't asked?
I think just spread the word. And for those around the country, reach out to your local medical groups, medical societies, your hospitals, you're in an area where medical schools are, encourage them to invite speakers to come in to talk about these concepts because they are becoming something that people need to have at the beginning of their training and not at the end.
Absolutely. Absolutely. And I would just put a word out that we at the International Neuromodulation Society do have fact sheets specifically geared for those looking to talk with their patients about some of these conditions you mentioned and how neuromodulation might treat, as well as some background information written by officers and board members like yourself that I think would be particularly helpful as well.
Well, great. I look forward to seeing more podcasts. Thanks so much for the invitation.
Thank you.